Kathy, welcome. Thank you so much for coming to listen to the Lichen Sclerosus podcast. My name is Kathy, and this is our journey of learning about and living with lichen sclerosus. I bring you experts and people with LS to share their personal journey with you. This week, I'm super excited because I have an amazing expert, researcher. She's just all around awesomeness. Dr. Melissa Mauskar. She is on the board of the newly founded Vulvar Dermatitis Research Consortium. She's the director of general dermatology and women's health. She is the Secretary General for the North American branch of the International Society for the Study of Vulvovaginal Diseases. And along with seeing patients, she has so much time on her hands. She is an associate professor in the Department of Dermatology and the Department of Obstetrics and Gynecology at UT Southwestern Medical Center. So that was a mouthful because she, like I said, is all around goodness. Now, the reason that we're going to be talking to her today is because she just helped publish a new study. And when I saw this, I was like, sounds interesting, but I have no clue what it means. So I was like, hey, can you come and talk to us? Explain, what is this? And she said, yes, of course, because she's awesome. So we're going to be talking about the assessment of the cutaneous hormone landscapes and microbiomes in vulvar lichen sclerosus. Without further ado, here's my conversation with Dr. Mauskar. Thank you so much for joining me today and explaining this because, yeah, I was at a true loss. So the name of the study is Assessment of the Continuous Hormone Landscapes and Microbiomes in Vulvar Lichen Sclerosus. So let's start from the beginning and break down what that title even means.
Yeah, no, I'm happy. Thank you so much for having me on. Basically, this project kind of came from one of my collaborators, Tammy Harris-Tryon, gave grand rounds at UT Southwestern. So, different faculty members talk about their research. And during her presentation, this was back in 2020, depths of COVID, she was talking all about, hormones and the skin as a hormone producing agent. And she also talked about, microbiomes and sebaceous gland production. And I was like, wow, so many of the things you're talking about are things I'm interested in. So we set up a meeting. I love taking care of patients with lichen sclerosus. It's one of my great passions here. But when I spoke with her, she was like, you are seeing all the patients, but if you don't ask the questions, how are we going to find the answers? And so she really empowered me to apply for a grant. And so I got a grant from the Derm Foundation looking at this question about, we all know that there's tons of bacteria that lives on our skin, millions of different types of bacteria that change based on the site. So, in general, if your skin is dry, there's going to be different populations of bacteria that live there than if you have moist skin or, wet skin compared to skin that has more sebaceous glands that make basically the oil on your forehead and stuff.
Okay.
So we basically got together and came up with this project idea. And thankfully, around that same time, it was COVID. I was pregnant. It was a wild time that I had a research fellow, Hunter Pyle, who's the first author on this study. And he really helped us gather these patients. And so for this group, we had 6 patients with vulvar lichen sclerosus. And these were patients that had not been on any type of topical therapy that had severe clinical signs of their disease. So we got this group of 6 postmenopausal women with lichen sclerosus, and we took skin samples. So we sampled different sites on their vulvas. So the clitoral hood, the interlabial sulcus between the 2 lips, the labia minora, the vagina. And then we actually did a kind of control sample. So I stood there for 30 seconds with my hand in the air, trying to see what kind of bacteria were living in the environment, because that can also kind of change the results you get. Uh,
Oh, that's really smart because then you can deduct that from the
exactly.
sample, and it's like,
Yeah.
okay, it's not cross-contamination.
Yes.
Perfect.
Exactly. And I mean, I think these studies, this is my first translational project, which was super exciting. And I love collaborating with other doctors. So working together with
Okay.
people to find answers is kind of what I'm all about.
Okay. I was
So
gonna ask, what does translational mean?
yeah,
Okay.
so no,
So
it's a great question. No, no. So that means basically you have ideas that you see in the lab, right? And all these things that we can study under the microscope. And
okay.
then you actually, instead of studying them on, you know, mice or non-humans, you take those questions and you look at them and how they are in real life. That's what
Okay.
that means. And so it's kind of working together to get those answers.
So to be
Uh,
clear, we're
yeah,
we we're gathering these people and we're taking these samples because we wanna find out what are those bacteria that are on their skin.
exactly.
Got it.
And so,
Okay.
yeah, exactly. Perfect. And so basically we look at, um, we took all the swabs from the lichen sclerosus postmenopausal group, and then we had 12 normal control postmenopausal women that did not have lichen sclerosus.
So
So we
can I
did that.
ask
Yeah.
why we
Mhm.
have double the number of control to the people that actually have the condition?
That's a great question. So it's, we had such strict criteria for enrollment for
Mhm.
these patients. So, you could not be on any cutaneous or oral hormone therapy. Um,
What
you
is
know, so like your
cutaneous mean?
that vaginal estrogen. So we didn't want people that
Okay.
had any vaginal estrogen or that were on oral
Okay.
estrogen.
Okay.
Um, you couldn't be on a lot of medicines like systemic medicines. There's certain ones we kind of excluded, and so it kind of got our. And we wanted to have patients that weren't on topical steroids. And a lot of
Mm.
patients, when they come to me, a lot of times people, as you know, people have been to 4 or 5, 6 other doctors before they get to someone. And so
Mhm.
most patients had already been started on therapy.
Okay.
And so,
So they
in
could never have been on steroids or just not at this point, like a
not at
time
that
frame?
point. Yeah. So it was like,
Okay.
I think it was about 3 months.
Okay.
Uh, but but yes, we wanted people that hadn't already been on steroids. And then in research, you have to have a control population that is very similar, so that there's not other factors that could change your results.
Got it.
And so um, it was, we wanted to make sure that we had more control patients to see if there really was a difference, because the numbers are so low. I mean, ideally, you'd have 50 patients in each arm is what we call a control arm, and then the study population.
Mhm.
But also, I only had $20,000 in this grant, so
Oh,
it's a
okay.
very expensive to run all of these tests. It's
Got it.
super expensive. So at least $1,000 for each uh, person sample that we ran
Mhm.
for all of these different samples, because we ran a bunch of microbiome samples. We also took their blood to look at the different hormone levels in their blood, and
Okay.
then we sampled the cutaneous hormones. So it costs a lot of money to do all these projects.
And just to
Uh,
be clear, what is the definition? Because we're using the word a lot, cutaneous. What is the
oh,
definition
cutaneous,
of
yeah, it's a fancy word for skin.
Oh,
So
okay.
yeah, it makes me sound smart, but it means skin. It's like
Okay.
the skin. So yeah, it was cool. So we followed these patients. And then before their sampling, they couldn't use anything on their skin for 7 days. No sex 48 hours before the sampling, and then so we basically then started them on a topical steroid treatment. And then for the lichen sclerosus group, we resampled all of those same things in 10 to 14 weeks. So we brought patients back and then sampled those swabs to look at their microbiome, and then we sampled their skin hormones, after treatment too, because we were curious to see if there were any changes,
Mhm.
after they had been treated.
Right.
And we found some really cool stuff. Okay.
So, for the control group, they were only sampled the one time, but
Exactly.
the patient group was before and after the steroid use. And how often were they using the steroid?
So, as you know, we love topical steroids to treat lichen sclerosus, but how
Mhm.
I treat patients is every patient is it's basically tailored to their disease activity. So if I have patients that have hyperkeratosis or erosions, they'll get twice daily therapy. And if they don't, and I see just the texture changes, they'll get once daily therapy. And so although it's a similar medicine, everyone has to have a different regimen. And I think that's so important.
Yeah, definitely. And unfortunately, a lot of us don't get that individualized treatment plan, and we have to go by general guidelines and kind of
Yes.
work our way through it. So I love it. So each patient had their own individualized plan depending on their condition. Okay,
Yeah. And
perfect.
what's different than what I would normally do if I wasn't doing a study is that lichen sclerosus has a lot of different factors. And so when I see patients in clinic, I tell them by the time people get to me, there's usually 3, 4, 5, 6 things going on. And unless we address each of these things, we're not going to get to goal, whatever that goal is for my patient. In our study, we also had to exclude, so people could not participate if they had any urinary incontinence. That's actually really common in our patient population. Just because it's common doesn't mean we can't do something about it. But
Right.
that was another exclusion criteria.
Got it. Okay. So now we're 10 weeks in. We've gotten the second samples. You guys do your thing in the lab, or you wait for the results from the
Yes,
lab.
which takes a year. It took so long. So
Oh my
Hunter,
God.
no, it is incredible to me. So this study started. I actually did the second sampling when I was like 3 or 4 weeks after having my third kid. So it was a lot. But then Hunter, who's he's going to be a first year derm resident with us next year. But he basically went to the lab and with our collaborators and helped analyze all of the findings because the hard thing that I'm learning about research is sometimes you have so much data, you just don't know what to do with it all, right? And so you have to find a story that will explain what we're seeing. And jumping to the conclusion, I think we found a lot of interesting findings and associations, but what that means for lichen sclerosis, I think we're still a little bit, far from. But I think it's just another point of gathering evidence and that will kind of hopefully in 5 or 10 years just change the landscape for all of us.
Yeah, and I want to get to that because I know um, one of the things you were really excited for was what this is going to bring in the future. So first, I want to talk about like what did you find, and then what do you see as potential benefits of this coming in the future? So
Yes.
what did you guys find?
So we found that in postmenopausal women with lichen sclerosus, they actually had higher progesterone on their skin. And so when you think about just, I guess, taking a couple steps back, so our body makes a lot of things. So it makes all these steroid hormones. And a lot of times our ovaries or testes make these hormones, or our adrenal glands can make these hormones. And our skin can actually make these hormones and contribute too. So there's a complex chart that everyone memorizes in medical school, all these hormones and precursors and enzymes to kind of explain how basically you get from all those precursor, early steroid hormones to kind of all the way down the path to the ones we know the most, like testosterone and estrogen. So in our study, the progesterone is actually kind of at the top of that chart. So it's a precursor. And so it's broken down in a lot of different ways to a lot of these other hormones.
Okay.
So that one at the very top of the chart was high on the skin. Ones
Meaning
that were
that it probably, well, I guess not drawing conclusions, but from what your explanation, if that one's really high, that means it hasn't been broken down into these
correct.
okay.
Yeah. So then down the road, when you look at the skin, so the progesterone was low. We measured at the groin and the forehead. So at the groin, the progesterone was high and the estrone, which is a downstream one, is low. At the forehead, interestingly, testosterone in the LS group was low, and 11-deoxycortisol. There's another one that was also low. But basically, 3 skin hormones were low and progesterone was high. So what that tells me is that maybe there's a step along the way that may be broken, why there's like that backup. So like if you think about like a dam, right? So all that progesterone being backed up means lower levels down the line. Now,
Right.
yeah.
One question, why the forehead?
Yeah. So we wanted to pick a site that was very prone to getting lichen sclerosis and one that I have just never seen lichen sclerosis before in my life.
Got it. Okay.
And that also, so this sampling technique, it's really cool to measure skin hormones. My collaborator has, it's called SEBA tape. It looks like Scotch tape and you put it on your skin. And she actually used that in a different study to look at acne and hormones. So that's a site that she had already established as one to measure too, but also as one that, basically you'd never expect to see lichen sclerosis.
Right. Okay. I was just wondering.
It's great
just
question.
it's just another like kind of control, but on the actual patient.
Yes.
Got it.
Absolutely. Yep.
Just to be clear, so that I'm understanding this correctly. So what you found was that the progesterone, which in normal function would break down to, in this case, either testosterone or estrogen, was higher and the estrogen was lower, meaning which you could conclude or hypothesize, let's use scientific for my ninth grade scientific term. You can hypothesize that something is not breaking down the progesterone into the estrogen properly, the way that it would in a healthy vulva or on other places of the body that do not have LS. Am I understanding that correctly?
Yeah, no, you are. And what's very interesting about this is, again, sometimes to see these kind of differences. So in science, we call it if it's statistically significant. So, that there's a huge difference between one group and another. And usually to find those differences, you need very, very large numbers of patients to see that. And in our study, it was really exciting for us because there was small amounts of patients, but still a lot of significant results. So that was cool. But what that also means is that we still, this is one small patient population, and we really need to look at, different patients and more patients and see if this continues to hold through. There's so many more questions that I think this study brings up. The other half of the study, so not only hormones, we also looked at the microbiome of these patients.
Okay, so explain microbiome to us.
Absolutely. So basically, all of us have all these bacteria living on our skin. One that's really common for healthy skin that we also want for our vulva is Staph epidermidis, which everyone knows Staph aureus is the scary one that causes all problems.
Yeah.
But this other one is actually good. And so it basically protects your skin and helps make moisturizing factors, that kind of stuff. Okay. So there haven't actually been a lot of studies or people looking at the vulva microbiome. There's tons on face, skin, you name it.
Gut.
But yeah, gut, tons on gut.
You hear the gut one all the time.
Yes. And I think the big thing when we're talking about microbiome is just because we notice something, and I tell this for all my patients who get all the swabs who come to see me. I'm not a sender of swabs or measuring this test or, but just because you can find it doesn't mean we know what that means. And it doesn't mean that it's driving symptoms.
Got it.
So anyways, so on our vulvar, we took, I did a clitoral hood sample, an intralabial sulcus, the labia minora, perineum, and vagina. So we sampled all those spots looking for the microbiome changes in our patients with lichen sclerosus and our control patients. What we found is the area of the intralabial sulcus was the one that we noticed differences in. And so what are differences? What does that mean for microbiome? On the skin, you want a really diverse microbiome. So you want a lot of different things that are contributing. And at the interlabial sulcus, we had a reduced diversity of organisms, which then after treatment, you got all that diversity back that the control groups had.
Oh,
So it was pretty cool.
interesting.
So it's like
Even
everything. Uh-huh.
is it question, even if patients weren't applying steroid in like, not everyone has active LS there, so I would imagine not everyone was applying in that area
No,
even
I mean,
within.
I think for normally how I treat lichen sclerosis is, I want patients to hit all of those target areas.
Oh, okay. So
Yeah.
I know there's 2 camps. There's the camp that only wants you to put it where you have signs or symptoms, and then there's the camp that it's like apply it all over. I'm camp B. But yeah, okay, so you're camp B as well, just apply it all on the
Yeah.
and
I mean, I
hit
think
all the spots. Okay.
yeah, I have different. I mean, I think all the patients we included in our study and that was another hard thing about recruiting patients is they all had to have activity, right?
Mm,
So I think it's like a lot of patients I'm seeing now actually have, you know, less severe clinical changes than they probably did 30 years ago because of people like you and the
mm,
awareness that you guys have been spreading, which is amazing, and for people advocating for themselves, and seeking out treatment and not accepting answers or
yeah.
wrong answers, no
Answers,
answers.
yeah.
Hmm.
Gaslighting, yeah. Got it. So, that's awesome. I love to hear that. So, yeah, people are getting in sooner, meaning that they don't have as many signs or symptoms because LS is progressive. So, we catch it early, we get a hold of it, you have less, signs, symptoms, and severity. So, I love that. Okay, so everybody's applying the steroid
Yeah.
everywhere, just on different they may have different schedules because it's
Yeah.
depending on their condition. But the microbiome was significantly improved after treatment,
Yeah,
is what you
it
found.
had, yeah, exactly, more diversity. We also looked at the fungus, like different types of fungus that live on our skin. And I don't
Mhm.
know about you or in your, the network that you guys have created, but I see so many patients that have Candida glabrata. And it's like, what do you do with Candida glabrata? Well, really cool part of this
Well,
study. And it,
before you go
yes,
on, just to
yes,
make sure, so for those who don't know, that is a type of yeast infection because a lot of people don't understand that there are different types of yeast. They just think, oh, it's a yeast infection. And most people, they're told your mom tells you go to over the counter, get some, I don't even know what they are, any Vagifem, whatever it is, and it'll clear your yeast infection. But we really should be going to our provider, getting swabbed because there are different types of yeast, and some of them may be resistant to an over the counter. And and you're letting it grow and get worse or whatever. So this is a type of yeast that is commonly seen. Um, and so go ahead. I just wanted
yeah,
to
no,
clear that up
you're
for
s-
anyone.
you're so good, Beth.
Oh, thank you.
Um, uh, so yeah, so what's interesting is, you know, well, first off, when you think about lichen sclerosis, I'm sure all of your listeners have been diagnosed as having a yeast infection. And I tell my patients, I didn't see you back then, but
Mhm.
that's something that kind of piques my mind. If you have that yeast infection that doesn't go away, because could it be something else brewing, which I'm sure your
Mm.
listeners know very well. But for this study, we found that there was actually less Candida glabrata in the VLS group. The control group had much more Candida glabrata, even though they didn't have any symptoms. So
Wow.
I was always taught that most often Candida glabrata is along for the ride. It may not be causing all of the symptoms. And that's not true in every single patient. I think all of us have had all doctors and probably patients have had, maybe symptoms that got better after treating the Candida glabrata. But again, this is something that I think is super interesting and I'd love to kind of dive in deeper in the future of. But basically, that we notice that difference too. And again, just because you notice something doesn't mean we can draw specific conclusions, but it's just more kind of information for us
Yeah.
to be able to know about this story.
Right, because that could be a future study at looking at, is there something in maybe the steroid that is, killing this yeast, or is that the right word? Killing the yeast?
Well, I think what's interesting is,
Getting rid of it.
yeah, no, I think that there's just so many levels of ways that we could look at this. I mean, I think what I'm excited about is, again, collaborating with people, and because coming to these treatments and study design from different perspectives is huge. And so,
Definitely.
I think that when gynecologists, urologists, dermatologists, and our patients all work together, we can do anything. So I
Yes.
think that this is one thing that I loved collaborating with my, colleague here, but I've also kind of built up a network of, you know, people interested in doing vulvar research in the country and, through ISSVD also around the world. And I do think there's so many people now interested in taking care of patients with lichen
Mhm.
sclerosis or other conditions that 5, 10, 15 years down, and so many medical students, residents, there's such a movement right now, people wanting to take care of patients with women's health concerns, that I think in 5, 10, 15 years, everyone's just gonna have a different experience. A
I
lot, because thankful because of a lot of stuff you're doing too, just getting people to know they're not the only person that has this, giving them a network, giving them a resource. It's incredible. So
Thank you. Yeah, I've been for when I first started, actually, I think it was like episode 2, I was or 3, I don't remember. I did an episode where I was like, we in the vulvar health, area need to have a movement like breast cancer, where we get to a
exactly.
point where all of the different um, medical modalities come together and have a coalition and collaboration, that they share ideas, because it's not going to just be a gynecologist. It's not just going to be a dermatologist. It takes everyone to put their different zones of genius together to really come up with the solution and really look at this from different angles. So I love that. So what is it that you are like, what are some studies or some things that you're looking forward to that get you really excited in the future of what could come out of this study?
Yeah. So the one I'm probably most excited about is for my patients. I want to try to find premenopausal women before they have any architectural or clinical signs of disease. And so what I would love to do is to extrapolate, to study what we're looking at here in premenopausal women, because I have so many that, through different life transitions. So looking at their cutaneous hormones during pregnancy, when they're breastfeeding, over their menstrual cycle, over through that perimenopause and menopause period. So we're talking probably a longer term study. But how do these, because all of my patients say that, oh, during my period, or this many weeks before my period, I get flares, or gosh, this came out after this surgery, after childbirth, or so I think that it's going to be really interesting to measure those cutaneous hormones and see what role they may be playing in disease flares. And so that's what I'm really excited to look at next
I
personally.
love that. Yes.
Yeah.
Especially like you said, around like the menstrual period, the cycle, we get that, we hear that a lot, that people are flaring at certain points in their
Mhm.
cycle, which to us non-scientists, non-medical people, it's like, okay, so is there a hormonal component to this LS that is, being affected by the menstrual cycle? Same thing, like you said, after childbirth. Is there a hormonal, or when you're breastfeeding, is there a hormonal component? So my question then is this hormone that is then just living on the skin, or is this a systemic hormonal thing? And I guess that's where the study comes in, right? It's like
Exactly.
looking.
Exactly. Yeah, and I think what's hard is that in the 80s, there was a study that came out in the New England Journal of Medicine that systemic testosterone was low in patients. And that's when everyone started throwing topical testosterone. And we had all these like 90s studies in the 90s looking at progesterone and, testosterone. And the results were really confusing, and steroids
Mhm.
went out head over heels better than any of these topical treatments. So I think that some of that foundation has already been laid. So again, I think all more questions to ask, and is there something else, that could be contributing to that improvement? And I mean, even from some of my patients that come in when they use emollients, and I'm not a big proponent of one over the other. I have maybe my favorites, but I think that basically if you use something topical on your skin down there on your vulva, then you're going to feel better because it's hydrating that skin, you know?
Mhm.
So I think that, I don't know, I think we have so much more work to do. And thankfully, people that are interested in working together to get those answers.
That's awesome. So is this, are you planning a new study based off of this? What are you looking at doing next?
Yeah, we're in the process of writing grants, which takes a long time. But yeah, we're looking at future studies, and like I said, I think looking back at my patient population, but really trying to expand to different patient populations. All of this though takes time, and when you're at a university like mine, there's we just need to make sure we do the right things. So
Mhm.
you have an a internal review board that looks at the studies you want to do and make sure that it's safe and protects patients and going about it in the right way. And then there's, different agreements if you want to work in between institutions. But again, all of this, it's a very exciting time for LS, and I love and just vulva conditions, I feel like in general. And I love meeting with medical students and residents that really want to dive head forward into this. They are in clinic with me, and I love being able to share this experience so that hopefully we train more doctors. And I think there's so many educational efforts that all of us are doing, to people that maybe, more than half of my patient population is a postmenopausal woman with LS or a premenopausal woman with
Mhm.
LS. So I think just educating everyone about this condition is super important.
Yeah, I think it's super important that a lot of providers who are not keeping up with like the current research, understandably, they can't be all of the places all the time learning all of the things. But it's important at least to get the message out to these providers that LS can happen at any age,
Yeah.
because it's unfortunate how many times people who are still reproductive age here, you can't have LS, you're not old enough, you're too young. It's a yeast infection or it's herpes because you're too young to
It's
have
atypical
LS.
herpes. It's atypical. I
Yeah.
mean, your swabs are negative, but it has to be herpes.
Right, or it's a yeast infection, or it's a recurrent yeast infection, but your swabs are good, but yeah, but trust me, it is, it's just not showing up. It's like, "Really?" But yeah, or that they don't even swab. Like, my origin story, as I call it, the gynecologist came in and saw a blood blister and said, "Oh, it looks like a herpes blister, treat her for herpes." Never tested me, and thankfully I had a nurse practitioner in the room who was like, "I don't think you have herpes. I think I know what it is. Let me do some research." And she was able to diagnose me, but it took 5 years and 3 different providers, 3 doctors, and then thankfully the nurse practitioner was able to diagnose me. But yeah, there has to be a way to get that information out to more providers,
Yeah.
sooner, but yeah, but thank you so much for being one of the awesome providers and researchers, that we have in our community because, we need more of you. If we could clone you like Dr. Babb and Dr. Kraft, Dr. Goldstein, um, there's a bunch of
They're
other
coming. No,
doctors.
there's
Yeah.
so many people, like I said, that I just want to leave that, I guess, with your community that there are, sorry, so many people that want to study this area, which is so cool for me to see.
Yeah.
So I think that, yeah, and I will give a shout out I work with a PA who is incredible. And she has vulva clinic at the same time I do. And I love working with her. And I think, as long as I don't care what kind of doctor you are, what kind of advanced provider, whatever, nurse. But if you are looking, then you are doing a lot for patients. So just
Yes.
to also
Yes.
spread that. So
Yes. Thank you so much. This has been so informative. I understand now, and I'm excited for the future. I hope my listener is excited too because great things are happening. Even in the 3 years since I started, I've seen the momentum building. And so I know menopause is having a moment right
it
now and
is
other
the
vulvar
Super Bowl
conditions.
ad. There was a Super Bowl ad. It was like number two. Oh my
I know, I know. It's amazing. So we're chugging along, we're getting there, and I look forward to your work in the future. And thank you so much for coming and educating us.
Thank you for having me.
So, I hope that now you understand as much as I do what this study was and are excited about the future, are excited about the kids who are in, or yeah, kids to me, but the people who are in medical school who are going to be coming out of there excited about treating and learning more about vulvovaginal conditions because they are so far and in between, and it's so needed. So needed. Not just in dermatology, but in gynecology. There is just this explosion in women's health, and I'm here for it. I'm so here for it. And I hope you are too. So, if you go to our show notes, you will find the link to the abstract for the study. And you will also find Dr. Maskar's IG. She is new to IG, so go and follow her. And if you are in the UT Southwestern area, and you need a dermatologist, hit her up. Okay. Thank you so much for watching and listening today. Until next time, have an amazing day. Bye.